Okay, it's 4 minutes after 4, Thursday the 24th. Welcome again to the COVID-19 webinar series hosted by the Botswana-Rutgers partnership. We have been on a little bit of a hiatus. It is winter. We've been hiding. Our talk today is going to be on COVID-19 DHMT updates, or district health management team updates in the Boteti region and the Kgalagadi South. I think it's very important, since we've had these webinar series, to really find out and chat to our colleagues to find out how things are, both from a public health point of view as well as a clinical point of view, as the DHMT offers, or it is the core to the response of COVID-19. As usual, the author is co-organized by Ministry of Health and Wellness, University of Botswana, Harvard Partnership, and Rutgers University. You can join the mailing list by emailing VUSI, vndaba@globalhealth@rutgers.edu, as you see over there. The sessions are over Zoom, and as part of our house rules, please do mute your microphones during the talk when the speakers are speaking. You will have a chance to ask questions at the end, where there'll be a Q&A. And also during the talk, there are moderators who will monitor questions, and they will respond to them as the talk goes on. The sessions are recorded and made available after each session, and they are posted on the COVID-19 Echo via YouTube. So if you search Botswana COVID-19 Echo, you'll be able to find all these sessions, including the ones that we've had last year. And we appreciate feedback via emails and suggestions on how we can improve the topics that you'd like to share or have us chat about on these webinars. So this is where you can find the previous sessions. Actually, as you can see, we've had one since last year in April, where we've talked about the management algorithm. I do encourage people to check these out. Next slide. So this is a very, very important site, or an area of expertise. It's the COVID-19 portal.gov.bw. It's a site that offers different options with regards to COVID-19 in Botswana. But I think the most important will be the document library. When you click on that, you will find that clicking on the document library, a whole host of guidelines come up. Clinical management guidelines, next slide. Clinical management guidelines, guidelines for adults, guidelines for pediatrics, guidelines on how to open up a center, guidelines on how to isolate people, guidelines on how to guide people within a district. So this is very, very important. So people actually always ask me where they can get guidelines, and this is exactly where you can get them. Next slide. So without further ado, as I said, today we are having updates by the district health management team. We have our very own two teams. Firstly, from the Boteti region, I'd like to introduce Dr. Phuswane-Katse, who is a public health physician currently working with the Ministry of Health and Wellness. She's based in the Boteti DHMT region, and she heads that region. She has over 8 years experience with both clinical and public health medicine, graduated from St. George's University in 2011, and has been working in Botswana since then. I know she has a passion for pediatrics as well. She currently works as a public health specialist with interest in curative and preventative medicine. She supervises those teams. And during the COVID-19, she has been involved since last year and works as a technical advisor to the COVID-19 response. She has been awarded the Gold Humanism Honor Award from the Gold Humanism Honor Society of the United States of America upon completing a medical degree. And she was the first recipient of the Mandela Washington Fellowship, which is a 7-week internship program, if you know about it. So she's quite well decorated. From the Kgalagadi South region, we do have Dr. Lelani Chikanda. Dr. Chikanda heads the Kgalagadi South DHMT. As soon as she graduated from medical school, she realized her passion was public health. And it was in due course that, during the COVID-19 response, she has showed leadership capabilities in setting up the COVID-19 isolation center and treatment response in that area. She has been advising the Ministry of Health and Wellness with regards to that area. And she works in close relation with Ms. Ramekwa, who's a nurse. So I also welcome that team. Without further ado, please welcome both teams. It will first be Dr. Phuswane-Katse and then Dr. Lelani with Ms. Ramekwa.
Thank you so much, Dr. Palai, for the beautiful introduction. And thank you everybody who's taken their time to come and join us today. I'm just going to be doing a brief overview of the DHMT COVID-19 response. And I have to give a shout out to the team this side. This is not a one-person work, it's a team effort. We all worked to make this presentation what it is today. Okay, so just a brief overview of the district for, somebody's controlling with me. Can I go back to the previous slide? Yes, just to the previous one, the overview of the district. Yes, just an overview of our district. It's for most people, it's part of the central district, but we are bordering Dodoma and Serowe. And for most people, they think Reikops Letlhakane are two different things, but it's actually within the same Boteti sub-district. There are 20 villages and 219 settlements, which makes our work really hard during COVID-19 because we have to reach out really far. And we have two COVID zones, the Talamabele gate, which goes to Francistown, as well as the Makoba gate, which goes to Serowe. We have 2 primary hospitals. We have 6 clinics, 12 health posts, and 1 private hospital, which is the Orapa Mine Hospital. We do have about 6 private clinics that are here. We have dentists and ophthalmologists, physiotherapists as well in the district. So the district is growing by virtue of it being a mining town. Our COVID-19 organizational structure is what is there. Our public health emergency response committee is basically headed by Molaudi and the coordinator. And you have the PHS who's supporting both of them technically. And you have our RRTs that respond to the COVID-19 response currently: surveillance, risk communication, case management, IPC, and logistics. But we also have a separate team with Molaudi, which is basically the cornerstone of the response, where all of our problems go to and we ask for advice. Oops, sorry. Isolation and quarantine is a challenge, just like in many facilities. We currently have only 1 isolation facility, which is the Matsumo isolation, 26 bed capacity, and Reikops in the West has 4 has a 4-bed isolation capacity within the hospital, bed capacity within the hospital. Orapa Mine Hospital does have quite larger numbers compared to what we're having. They have the Khokong, which has a 56-bed capacity, Morengi, which is 5-bed. And the beauty of it is, if we do have cases that are overwhelming us, or it's business partners from the mine, they do take them in to be part of the to be isolated in their areas, as well as 1 quarantine site, the Khokong quarantine site, which is an 83-bed capacity quarantine site. And I think the milestones from this year in terms of management of COVID-19 clients have been the critical care units, the high care units that we have set up before we refer clients. Can we go back? Before we refer clients to say Kitumile Masire if we have to. We have the Letlhakane High Care Unit, which is a 16-bed capacity. It basically just offers care to those who need oxygen, as well as existing comorbidities, and they cannot be managed at Matsumu. Orapa also has a critical care, which is an 8-bed capacity with ventilators, and equipment that helps them take care of clients before they can refer that site. It also has a 16-bed capacity in the Orapa COVID-19 ward for their critical clients that are mild and do not need isolation with the stable clients. Next slide. And just an epi overview of the district. This are statistics as of the 22nd of June, but currently our cases are now at 5,028 compared to the 4,911 that is reflected there. Our total deaths have stayed the same at 40, which gives us a case fatality rate of 0.8. We are largely doing COVID testing via the rapid antigen method because we do not test for PCR within the district. But when we do need support, we send to Orapa or Francistown to run our PCR test. And that is mostly for clients who are either inconclusive or are symptomatic and still testing negative. Next slide. This is our overview of our isolation sites and where our clients are. As much as we seem to have a space for quarantine within Letlhakane itself and for the community, our isolation and quarantine spaces are really limited. And you find that 86% of our clients are mostly on home isolation, while only 38%, 14% are in Matumu, which is our isolation sites at the Reikops one. The same goes for our clients on quarantine. You find that the majority, which is 520, 97% are on home quarantine and only 3% are on facility quarantine. So I think it's dynamics that we really cannot be fully in control of, but we do try and make sure that when they're on quarantine and isolation at home, they follow the proper guidelines. We call on them almost every other day. And for our more difficult clients, we make sure that we go and visit them to make sure that they're still in quarantine. Next slide. This is a trend of our cases. And I think this is more relevant now as we're going through the third wave. And as the district itself is moving from the green zone to the yellow zone, as indicated in the previous updates, you can tell that our worst part or our worst hit was in February, where we reached our peak. And I think around that time, we were reporting around 90 to 100 cases a day. And now when we are in May, June, we've been reporting around 50 to 60 cases. Most of our cases come on Mondays post-weekend. And I think that's just by virtue of services provided during the weekend. They're limited and people are used to not receiving medical services mostly during the weekend. But we do still test on weekends, especially the clients that really need help. But I think the trends just show you that even though it looks really bad now, it was worse around February when the country was experiencing the second wave. And I think this is the trend with most of the district. And we're really trying our best to make sure that we do not move to the red zone. Next slide. And this is just the trend of our monthly cases as of the 8th of September. And this just reflects what we spoke about in the previous case. You can see that our definite spike was January, February of this year. And now we are having quite a lot of cases, but not as bad as it was in that first big wave. We've recorded 699 in May and only 295 up to today. So I think in terms of being hard hit, we experienced our worst cases in February compared to now. Next slide. And this is just a quick picture of what our cases are by age group and sex. You can tell we have sort of taken the trend that the country has taken. Younger people are being affected more. If you look at the 30 to 35 and 35 to 40, that is where most of our mortality is coming from compared to the older age group. They are there, but they're not as many as you would see. And I have to say most of the cases came around this second, third waves. That's where the cases increased to those. And we're not experiencing a lot of cases in the older generation. So I think this current wave is hitting us harder in terms of those who are 35 to 40 years. Next slide. And if you look at this is just a depiction of the gender, which gender is more affected. And of course, males are more affected at 2,319. That's around 47% of our total cases, and 2,228 females, which is around 46%. And we do still have reporting issues where some data is missing, and that was around 210 cases. We are trying to improve our completeness of our data, but it's still one of those challenges. But as you can tell, we have more males being affected. Yes, thank you. Yeah. And if you look at our mortality trends now, which has been the cornerstone of our conversations of recent, because we really want to reduce our challenges, we have those who are 60 to 64 being affected more and passing away more, with more males than females. And I think this can be attributed to the health-seeking behavior of males. They are less likely to come and present. And we've had few issues where they are not wanting to come to the hospitals and they think they can help themselves at home. So that is why we have that peak in the 60 to 64, but we are still seeing deaths in 45 to 49, as well as 50 to 54, and not as many in the older ages. Next slide. And this is basically just the same as that side, but this time it's more along the gender lines compared to the age, and males are being affected more, especially in the age range of 60 to 69 compared to the female counterparts. Next slide. And this is just mortalities by month and sex distribution. And again, it goes back to say February was where we were hit hard with 11 cases, with 13 cases being reported, compared to where we are now. Maybe we had 10, and June we are now having 13. But cumulatively, these two last months have been really hard on the district in terms of mortalities. Next slide. COVID-19 among healthcare workers. I think this is always an interesting pattern to see within our facilities. We have recorded 17 cases of COVID-19 among healthcare workers. 29 were males and 88 were females. And we've recorded 3 deaths in the district already: 1 doctor, 1 pharmacy tech, and 1 mortuary attendant. But even though we have deaths occurring within this cadres, we've seen our cleaners being the most hard hit by COVID-19 compared to the other cadres. We've got cleaners being at the forefront in terms of our COVID statistics in healthcare workers, followed by the nurses and then other cadres. Doctors are not getting as many cases as you would suspect. We have about 10 doctors who've been diagnosed with COVID up to today. And I think we can owe it to PPE and how we're using it, but still we're trying to reduce. We have continued engagements with cleaners on how to take care of themselves while they're cleaning. Next slide. And the vaccine update, which is the conversation as well. We have received AstraZeneca's, Sinovac, and Pfizer, and we saw last week the vice president was being vaccinated in the district, and that has created a huge demand for the vaccines. All of them, really, people are just coming forward to say we want the vaccine. Pfizer, Sinovac, AstraZeneca, they're looking for it, and the rollout started a bit later in our district than others. We started on the 9th of April. And Boteti DHMT has 5 depot sites, which is where we are rolling out our vaccines from. It's the Letlhakane Primary Hospital, Rakops, Orapeleng Hospital, Mopipi, and Motopi clinics. So these are our central points before we distribute the vaccines to the other sites. Our target groups are what is currently happening now and who we have given. It's above 75 healthcare workers and law enforcement. And our target has been 5,809. That is the numbers that we anticipated to vaccinate in this first round. Next slide. But as you can see, we have vaccinated a lot more than what we anticipated. AstraZeneca first dose, we gave 1,343 doses. And Pfizer, we've given 140 as of the 20th. And Sinovac, we've given 3,244, and second dose is going really well as well, 2,056. I think the latest statistics I got this morning was around 2.4 doses of AstraZeneca that were given. I think the question would be, why have we given so much when our target was little? Boteti is a mining town, and by virtue, we have a lot of movement into the mine. And that is why we have such numbers. And we are giving as many people as we can the vaccine without wanting to say, do not take it or take it. Next slide. Also, when it comes to the total citizens and non-citizens vaccinated, we have vaccinated 2,822 males as well as 3,906 females who are citizens, and non-citizens we've vaccinated 53 males and 6 females who are non-citizens. And it's not surprising that we have non-citizens already vaccinated by virtue of where we are and the mining town that we stay in. We have a lot of skilled laborers that come in from outside the country to come and work within the mining town. Next slide. And we have unfortunately reported deaths secondary to vaccination or related to the vaccination as adverse events following vaccinations. We've reported 9 deaths so far, 7 from AstraZeneca and 2 from Sinovac. The deaths or those who passed also had comorbidities that they were living with. So it was always a tricky situation to say, is it the vaccine or not? But the causality reports are being done by the team that is doing adverse events, and hopefully we'll get to find out if it was the vaccine or not. And also, unfortunately, we're not able to do our postmortems for them because of issues around postmortems and families agreeing or not agreeing to the postmortems. But I think so far there hasn't been any negative impact from the deaths because of vaccination. We're still seeing people coming forward to come and get vaccinated. We have reported a little bit back. We have reported over 97 other adverse events that were not serious. And the common symptoms were body weakness, joint pain, dizziness, headache, shivering, just the normal ones that we normally get. Next slide. And from the cases that were reported, we have seen ourselves, we have seen 5 test positive for COVID upon admission. So it was really a case of, is it COVID-19 or is it the vaccine? But I think we've seen a trend where after people get vaccinated, especially the elderly, they stop wearing their masks, they continue to live life as normal. So I think that's one target group that we're addressing, to say, once you get vaccinated, please continue to wear your mask. Next slide. And how has COVID-19 affected service delivery within the district? I think it goes without saying that COVID-19 has played a major impact on how we have delivered our service. And I think this is some of the key areas that we look at. And the numbers on both sides are Q1 and Q4, which is at the beginning of the year, of the first quarter of the year, to now. Where are we now? And if you look at condom distribution, we started at 113,000, and in the last quarter, which was the beginning of this year, we had 69,294, which shows that there has been an impact in how we deliver our services. Teenage pregnancies as well, especially in those under 15 years, have seen an increase. Q1, we only registered 1, but this quarter there were 5. The last quarter there were 5 teenagers who were pregnant, but the totals have decreased in terms of how many were registered for ANC or how many were total pregnancies. HIV testing, we were able to test around 1,964 in the first quarter, and the last quarter was 2,000, which means there really wasn't much of a difference in how we deliver our services. Community home-based care, which is another area which was critically affected. We started with 205 people enrolled, and we moved all the way to 225. And this was largely because families that could previously be able to take care of their relatives who are on palliative care could not do that anymore because of the economic status. So they had to now rely on government to be able to help them take care of their own. Safe male circumcision was hit hard, is really hit hard. We started at 24 and now we are at 0. And we're currently trying as much as we can to try and revive that service. ARV, We initiated Q1 95, and this last quarter we're able to initiate 195. And upon a small focus discussion with people who came, people have migrated back to their home towns because they cannot afford to stay in the big cities anymore. So some of them are being initiated here as well. They can't move back and forth to get their ARV, so they have to get them where they stay. And cumulative tests that we did, cumulative people that we had from Q1 was 9,612, and now we have 10,916. PMTCT was largely unaffected, and it stayed the same throughout all the quarters. TB, we saw a huge reduction in our TB cases. We currently only have 2 MDRs in the district, and I think we have to applaud the fact that our wearing masks has stopped the transmission as well. We can hypothetically attribute it to that. The EPI program was hugely affected, mostly when it comes to the supply of ORS and zinc. We started at 80.7% and we are currently at 46.2. We've also registered 2 mortalities. I think when you look at our EPI program, it's one of the programs that has been hit really hard. Also, issues that can we go to the next slide? Yeah, if you look at let's go back, let's finish EPI. If you look at how the distribution of vaccination was, it's also been affected greatly. We haven't been giving as many vaccinations. We came from 90% to around 63% of our vaccine delivery. Next slide. And despite all of this challenges during COVID-19, we've been able to establish a high care unit in Lelani Primary Hospital, which really helped in terms of managing acutely ill clients, as well as the expansion of the Matumo isolation by an 8-bedded institute porta cabins. And I have to say the Matumo site has been greatly expanded by our stakeholders. Orapa took over the renovations of the isolation, and the porta cabins were donated by Lukara Mine to help us be able to house more people. Continued risk assessment and testing are happening within the students within the district so that we can curb the new Ntasa pandemic that is going on as well as engagement with community leaders, traditional healers and churches. I think the beauty of being in a district is it's a big, beautiful village and everybody wants to take part in controlling the pandemic. And like I said, continued support and collaboration with stakeholders. Next slide. And we do have challenges, but I really don't like to call them challenges. They are our growing pains. We continue to see non-compliance to the prescribed COVID-19 prevention methods. There are parties going on, there are weddings, but we continue educating as well as we continue passing the messages on our billboard. Law enforcement is also very big on helping us with curbing the social gatherings that are happening. Inadequate staff during our search period, February, March, May, and June. We have been very innovative in using other staff hired for COVID-19 to help us with the cases. Limited infrastructures for home and institutional quarantine. We have largely gone to using home isolation and home quarantine as our way of managing our cases, as well as using our boarding schools for students as isolation and quarantine sites. We partition their boarding rooms and we make sure that this side is for isolation and this side is for quarantine. Lack of renewals for temporary staff. We are pulling other healthcare workers to come and assist within the COVID response. Transport challenges. We only have 1 ambulance that is supposed to service both East and West. We are trying our best. When it's really hard, we call on our partners to help with the ambulances. Temporary food relief for those on quarantine, because once they don't have any food, they leave quarantine. So we work close with the sub-district council to make sure that we have food for those who are on quarantine. And Boteti, for those who know, it is a really challenged district. We still have people who do not have basic water in their homes for quarantine. So we do bounce potable water to them through water utilities. Next slide. Recommendations, really, we would love to expand the vaccine rollout to larger, more at-risk communities. We're talking about our teachers, we're talking about health police officers, and other people who work directly with the community, as well as possibly target our key areas or large areas, or Orapeleng and Reikops. If they're fully vaccinated, then we're sure we are going to be going in the right direction. Temporary COVID-19 stuff, so supposed to be 10. This one, I have to say, it has been listened to. Thank you so much to the Ministry of Health. We received temporary staff here as HCAs to come and help within the pandemic. And like I said, we have only one ambulance. We could use with a few more, and vehicles suitable for the terrains. It's really hard to travel within the district once we have rains, and others are really sandy, which makes it very difficult for us to maneuver. Next slide. Thank you so much.
Thank you so much, Dr. Phuswane-Katse. I think at this juncture, I'll hand over to the Kgalagadi South Regional Health team to give us the update. I must thank you, Dr. Phuswane-Katse, also for trying to stick to time. Over to you, Kgalagadi South Regional team.
Yes. And then only pick.
Good afternoon.
Afternoon, team. You can just hit the slideshow button, the bottom right hand corner.
Good afternoon, team. The one speaking is Dr. Chikanda. I think Dr. Palai has already mentioned the introductions. I will go straight into the presentation of Kgalagadi South. The outline in such a way that I'll just touch briefly on current situations and the impact of COVID-19 in Kgalagadi South, and the successes and the challenges that we faced in Kgalagadi South, and the interventions that we tried to get into to try to make the situation better, and touch briefly on the vaccine rollout and the recommendations that we have. In terms of the background, Kgalagadi South is located in the southwestern part of Botswana and forms part of the western region. And Zabong is the district headquarters and is 530 kilometers from Gaborone. Kgalagadi South is spread from Kokotsa in the east to Stresendam in the western part. And Kokotsa, by the way, is 200 kilometers to Zabong, while Stresendam is about 280 kilometers to Zabong, making the district vast in terms of the distance. The total population of Kgalagadi South is about 35,164 as of the demographic survey of 2017. In terms of the healthcare delivery structure, Kgalagadi South has 22 health facilities, including one primary hospital, which is located in Zabong, and it has 21 villages. In order to manage these villages and these facilities, the district has managed Kgalagadi South into 4 clusters or catchment. We have the Zabong catchment, the Beda catchment, the Middlebits catchment, and the Boravas catchment. And all these catchments are manned by the D4 NES, and only one catchment, which is Beda catchment, has a doctor. So in terms of the current situation into the era of COVID-19. We have, as of the 22 June 2021, we had a total of 2,154 cases, including 19 deaths have been reported since August 2020. And currently we are at 157 active cases. Since the beginning of 2021, we had 2,095 confirmed cases in the district. Sorry, we have 2,095 confirmed cases in the district. And as we have seen in the, if we can see the graph on the right, which shows the trends of the positive cases since August 2020 until June 2021, we are seeing our influx of cases, or our peak in May, which is our peak in May, which is 636 cases. And so far we are in June, and we are about half the cases of the cases that we have seen in May. We have noticed that in our district, these cases that we see are seen in clusters. For example, most of the cases, for example, what can explain the cases that we have seen in May is because of the involvement of the cases in schools. For example, in Veda, we have schools being affected in the junior school in Middlebeats and the junior school in Veda catchment. And we have also seen that if a case happens in an institution or in a department, almost majority of the people that work there, they will be affected. Currently, we are doing home quarantine. We don't have any facility or any infrastructure that we can be able to quarantine clients on. We have an isolation site, which is Zabon Clinic, and we also do home isolation to majority of our clients who are on isolation. In terms of the case of the confirmed casing and testing ratio, we can see that from the month of January, our testing rate really peaked from more than 1,500 to in April, where we did close to 2,500 testing. And as we kept on testing, our confirmed cases kept on increasing. In terms of the impact of COVID-19 on our healthcare delivery, during the beginning of COVID-19, we have seen an influx of flu-like illnesses coming to our outpatient department, which resulted in congestion in the clinics and even in the hospital. The influx of patients, most of them were requesting to be tested for COVID-19 and also to be screened if they have COVID-19 or not. The other challenge that we faced is the resources. We had very, very limited resources in Kgalagadi South. And as COVID-19 came in, we had very, very little resources to offer to COVID-19. For example, we have little to no enough personnel that can help in both the normal duties of outpatients and also to cater for COVID-19. We have challenges in transport, and we also have challenges even in the infrastructure or the facility itself to cater for patients who are also COVID positive. We also had our attention being diverted from COVID-19, being diverted from other conditions, for example, the non-communicable diseases into COVID-19. We pulled out officers who are doing programs, for example, the HIV, the TB programs, the SMCs, the family, the cervical cancer screening program to help in COVID-19 response. And this crippled so much the attention that we give to the conditions in the programs. As the surge of cases became evident in January to February, And to date, we are still requiring new interventions. In terms of our success in this response, we had in Kgalagadi South, we had very great support from the community leaders. For example, the councillors, for example, we see them helping us with community mobilization. For example, noticing the public of our ongoing vaccination, they will lend us their PA system to help in mobilizing the community. We also have existence of LOC in all the villages and ability to use the surveillance to guide interventions. For example, we'll look at our epidemiological data. Where are the cases so that we can provide strategic plans so that we can tackle the COVID-19 situation in that particular area. And then the other success that we managed to do, we developed a search strategy in January 2020 as we were noticing very high cases of COVID-19. That maybe will be evident as we move on during this presentation. And we also had continued health education to the community across all the villages. We have never stopped mobilizing or educating our community, as we believe that is the cornerstone of our strategy in containing COVID-19 infections or transmissions. In terms of our unique challenges or the challenges that we face in the district, first of all, we had difficulty in containing the virus simply because of the communal living arrangements, especially in Zabong. Our district is full of people with low socioeconomic status and also which resulted in some people living in overcrowded homes, which was difficult for them to comply with the COVID-19 protocols because of those low socioeconomic status and also the living arrangements. We then faced challenges of high oxygen demand, especially in the period starting from February. Our oxygen therapy increased as we started receiving more sick patients from COVID-19. Then it resulted in transport going from Zabong to Gaborone every single day to refill up the cylinders for oxygen. And the vastness of the district, like for example, the significant distance between the facilities made it even more worse in terms of the transport issues. We have challenges with our turnaround time for our PCR result, which is done in NHL, as the results take about more than 72 hours as we are catering for the traveling distance, as most of our samples are carried by the post office. So it takes about 1 hour for the results or for the tests to be dropped to National Health Lab. 1 day, yes. And we had also challenges in convincing our community in the difference results that we get from the rapid test and the PCR results. Most of the time we are utilizing the rapid test, but we see ourselves in situations whereby a patient will come clinically presenting COVID-like presentation, but the rapid tests come back negative. As we do the PCR and it comes back positive, to convince the family members becomes a really, really huge challenge. And they start now not trusting the health system. We have another challenge of our weak surveillance system, for example, reports not done on time, possibly due to the lack of personnel that needs to report in real time, as they are busy engaged with other duties. And I also mentioned that we have lack of isolation facility and quarantine facility, which made it a very huge challenge in containing the transmission of COVID-19. For example, you'll find that most of our clients, if they are on quarantine, they also have a client who is also positive, who is also on isolation. And this resulted in the cycle of transmission not ending because they live in the same environment. And then we had challenges whereby the livelihoods also adding up to the already existing challenge of not having isolation facility, them not complying with the COVID-19 protocols of isolation and quarantine due to their livelihoods, where they will have to go back to the village to look for food, to look for piece jobs so that they can feed their families. All the villages are along the border with South Africa, except for 2 villages. And this resulted in tempting the residents to jump the borders, leading them being in quarantine. And this depleted all our resources as we were quarantined, all of them. And then we had long distances to Gaborone. A single trip required about 2 days. And this attracted all the transport being in Gaborone most of the time, and even our personnel being in Gaborone for a period of more than 2 days. And we had inability to airlift our patients at night due to lack of required lighting at the airstrip. And which means if we had a critical patient at night, a COVID-19 patient who is very critical, we'll have to monitor that patient. We cannot intubate the patient or do anything of that side of those kind of interventions at night, because we cannot assist them at night. We have to wait for the morning. And then we had to close Sabon Clinic so that we can cater for the isolation. And this resulted in congestion at the main hospital, which is the primary hospital. But of note, Sabon Clinic is the only clinic that is in the village. So most of these patients now go to the primary hospital to seek medical attention. In terms of addressing these challenges, we then, as we were noticing the influx of flu-like illnesses coming to the hospital, we then opened up COVID-19 screening and testing facility, which we did in August 2020 to help ease the congestion that we had in the primary hospital. And we also converted the only clinic in Sabon into an isolation facility in February 2021, as the cases of patients who need oxygen therapy increased. We then redeployed the nurses from other facilities to the isolation facility. We requested and was supported with 30 hospital beds from the headquarters. We had also additional equipment which were also gotten from the headquarters. We did more procurement of some critical items locally, and also we requested for more oxygen cylinders from the CMS. We then continued with the daily refilling of oxygen in Gaborone, and that's about 530 kilometers away. In terms of resources, we tried to request some healthcare personnel from the ministry, which they have supplied us with temporary personnel, the nurses and the doctors, but all of their contracts finished and it was never renewed again. We then engaged temporary employees like cleaners, night watchmen, kitchen handmen, and laundrymen. Remember, we then opened an isolation facility, which is a 30-bed, and all this laundry and feeding comes from the kitchen of the hospital. We also had, remember, challenges of the transport, which we requested transport from the CTO and other departments to support the response, in which they gladly helped us. And also CTO is giving priority to the RHMT vehicles when we need help. As the way forward, we believe in Kgalagadi South, we need to work hard on the aggressive community mobilization and education, as we notice that if we wait for the patients to get even more sicker our challenges becomes even more worse. For example, the oxygen therapy and the nursing care that is necessary. We also want to engage, we already started engaging the community leadership to help us with community engagement so that they can own up to the COVID-19 response. We then strengthened our surveillance team so that it can be able to give us enough epidemiological data to guide the response and the interventions. And we also want to rejuvenate the district RRT team. As for the COVID-19 rollout, we had a target total population of 7,622, 75 and above, we had about 773 as of the pensions register, and 65 to 74, we had 2,903 from the national estimates, and the healthcare workers, we had 404 from the head counts, and we had 4,053 from the national estimates of 55 to 64. So far, we have commenced vaccination on the 9th of April 2021, vaccinated 640 people with 590 doses from AstraZeneca. And from this AstraZeneca, we had 19 people presenting with minor adverse events, which most of us maybe we are already aware of. On the 10th of May, we received 1,770 doses of Sinovac targeting the group of 55 plus. And in this 1,770 doses, we vaccinated 1,769 with the first doses. Currently, we are on our second doses of Sinovac, and we have vaccinated only 617 as of 22 June 2021. And the vaccination process is still ongoing. And the successes that we had, the vaccine for 75 target was delivered in 2.5 weeks. So far, over 80% of our target population was entered in DHIS of the vaccinated population. We had very minimal wastage of our vaccines, both from the AstraZeneca and from the Sinovac, only one dose so far. Local community have been mobilized, evidenced by the very the increased turn up of vaccination. And all villages have received some doses. There is no village that we have never covered with vaccination in Kgalagadi South. And the good part about it is all the healthcare personnel are aware of our vaccination rollout program to try to minimize issues of people who are vaccinating not being there and no vaccination process that is ongoing vaccination. So we acquired community halls from VDC and are being used as our vaccination sites. If you look at the infrastructures of our community, of our villages, most of them are very, very small, including even the Sabong Primary Hospital. There is no space. So the only thing that we managed to acquire is the community halls for the vaccination process. And we have never had any major adverse events from both AstraZeneca and Sinovac. And we keep on maintaining our cold chain, So in terms of the challenges that we face in our vaccination rollout, we have shortage of transport that has already been there even in the response of COVID-19, but we were given 7 vehicles from other departments, but they went straight into the already existing gaps of transport. And the vastness of the district in terms of the distance makes it even worse for us to be able to manage our transport. For example, just Middle Pits is 100 kilometers from the headquarters, which is Sabong, and Box Pits is more than 270 kilometers from the headquarters, which is Tsabong. So we had challenges in our vaccination rollout, which is data entry challenges. Of the 4 data entry officers that we were given or promised by the headquarters, we only received 1. So this is the person who is only available to help us with the data entry. We also have DHIS technicalities. For example, the DHIS is very slow in some of the villages that we live in. The clients who are already existing in DHIS for other programs are being rejected by the system, but we managed to try our level best to attend to those challenges. So in terms of our recommendations, we don't know whether it's possible, but we believe that installation of oxygen plant in our isolation center would really relieve some of the challenges that we have, the transport going to Gaborone almost every day to go and refill the oxygen cylinders. We will also be thankful for the additional healthcare personnel, and we wish that we can get help with the expansion of the kitchen, which is the hospital kitchen, as it's catering for even the isolation center, which is taking care of both the inpatients and other stable patients with COVID-19. And we also recommend that maybe we can install the backup generator, as the clinic does not yet have the backup generator. And we recommend for aggressive community education that we believe it will help us in containing the COVID-19 transmission. Thank you so much. This is our isolation facility for COVID-19, which takes care of the inpatients, those who needs oxygen therapy and those who are stable. We prioritize mostly those who are stable, or those who needs oxygen therapy as compared to those who are stable. That's the 30-bed facility that we have. Thank you so much.
Thank you, Dr. Chikanda, for that succinct and yet very detailed report from Kgalagadi South. I must thank Dr. Phuswane-Katse again for that. I'm looking at time. We will try to just go through or offer participants questions that they may have. I already see one on the chat box from Dr. Gaolathe, which I will share with everyone. So I think at this stage, if you want to post your questions on the chat box, please do that. If you do want to unmute your mic and ask questions or discussions, please do that. The question is to you, Dr. Chikanda, and your team in Tsabong. Are you using the oxygen concentrators for the low oxygen demand available at Ministry of Health and Wellness? Are you guys aware? Are you using that?
Thank you, Dr. Palai. Yes, we have received some oxygen concentrators. We have received only 4 oxygen concentrators, and we are only currently also advocating for more concentrators, because we noticed that they can actually be of greater help as compared to using the oxygen from the cylinders. Thank you.
All right. Okay, that's good. Dr. Gaolathe has posted another interesting question or comment from a public health and a clinical point of view, which is the data that is flying around, the mix and match COVID vaccines, which we know trigger a potent immune response, including the studies coming out of the Spanish trial. That if you mix AstraZeneca and Pfizer, you know, the response is more potent. And I guess the question to you guys is, what do you think about that?
I think, Dr. Palai, that's a very relevant question, especially right now where the country is experiencing a lot of vaccine shortage. it might be difficult for many countries to actually get the first and the second dose of the same, but where studies like the Spanish study has proved that if you got your first AstraZeneca shot and you get your Pfizer as a second shot, it literally boosts your immunity so that you get better outcomes. That is what would be recommended. Also looking at the variants are coming in really hard. So you really wouldn't know which variant you are targeting with only one. So it's been suggested that mixing the doses will be good for variants as well in the future. So I think from a public health point of view, as well as an economic or a vaccine shortage point of view, it's one of the best ways that we could try and fight the vaccine shortage as well as the variant issues so that we get better outcomes and go back to normal.
All right. Thank you for that response, Dr. Phuswane-Katse. I do agree. I have had a chat with some colleagues and senior people in Ministry of Health and Wellness. I don't think some people, or let me say, they are aware of the data, but it hasn't been officially been approved in terms of mixing and matching, and we do have to worry about variants. We know that the virus makes a lot of mistakes when it replicates, and we are going to get more and more variants, and we've had this discussion that we are likely to need boosters actually in the future. Dr. Gaolathe has also said, can we comment on a referral to high-level facilities? I think this is quite important for both the Boteti and the Kgalagadi South region in terms of finding a really organized referral system, and not only that, but being organized in terms of ensuring that before we refer at the right time, and when we do refer patients, we've ensured that we've given them the best possible chance to survive.
I think we have to commend Sekitumile Masire, despite all the influx of clients that have been coming in. They've made sure that the referral system stays as swiftly as they possibly can. And I think just with any system that is crippled during COVID, you find challenges where at the beginning we were really scared and we wanted to refer everyone to Sekitumile. But I think the doctors there were always confident enough to share how we can manage the cases here. And that has gone a long way because they've taught us valuable lessons on how to manage our clients here. And you find that in Boteti, we really don't refer unnecessarily. And we would call and discuss first before we refer. But I think it's COVID is a new illness and it's scaring many of us. So there's always those misses and hits when it comes to referral. We've created a referral pathway and we make sure that we follow it before we can send somebody elsewhere. If at Matsumu you don't do well, we take you to our high care. And if at the high care we see that you're really struggling and we're also struggling, that's when we refer you to Sekitumile Masire.
Okay, thanks, Doc. Another question posed to you, which I think is very important, and I think that will be the last question. I'm looking at the time, is deaths post-vaccination. Was there some form of follow-up done? And approximately what was the time between the vaccination and death? And probably just to add on to that question from Ado, is what were the circumstances? I think a lot of people, or a lot of the public, don't understand that sometimes when somebody is vaccinated, there may be comorbidities that contribute to mortality. But let's hear what you have to say to that question, Dr. Phuswane-Katse.
This is a very interesting question, and I think one that should be highlighted a lot. I think when we did it, our time ranges between the deaths. The first death that we recorded was actually 2 days post-vaccination, and the average time has been between 5 to 7 days post-vaccination. And coincidentally, all of the cases were who were presenting within that short time frame also tested positive for COVID. So it always brings in the question of, were they already COVID positive before and the vaccine did something, or was it just a coincidence that they were positive? We've had families speculate that we probably gave them COVID when we were giving them the vaccine. And that was something that our health promotion team had to react to very quickly to go over what the vaccines are and how are they made and all of that. So I think the longest we've had in mortality was one who was vaccinated in May and just passed away 2 weeks ago. That was the longest we've had. And like I said earlier, we're still waiting for the causality reports from the AEFI committee to tell us if there was any relation between the two. And I think circumstances, very rightly so, Dr. Palai, there are always comorbidities. All of them had comorbidities. And I think that's something that we should always highlight, that if you had comorbidities and you pass away, unfortunately, comorbidities and COVID infection do not go hand in hand. So many of them, almost all of them, had comorbidities when they passed. We haven't had a young, healthy person who was vaccinated passing away as a result of the vaccination. Thank you.
All right. Thanks, Doc. I think I do agree. I think vaccinating the older population or immunocompromised, needs to be done very carefully with a pinch of salt. Those kinds of populations do need some sort of close follow-up. Of course, everybody needs to be kept an eye on, which is why we have, I think the Ministry of Health has an electronic, and you do get a card when you get vaccinated to keep such records. We know that there was a lot of noise about venous thromboembolism, especially cavernous sinus thrombosis post AstraZeneca vaccine, which seems to have dimmed down. I think probably what we will need to chat upon in the next 1 or 2 webinars is update on guidelines. There is new information on Regeneron, or the monoclonal antibody, which seems to help, with spreading of COVID in between between household members. And then there's also tocilizumab. I think those two treatments we need to talk about and add to our guidelines in the next 1 or 2 webinars. I see people on the chat box. I think due to interest of time, it's 5:10. We need to end the webinar, but I see people saying they want reports from other districts. I think I'll speak with Vusi and Dr. Gaolathe. We will organize more webinars for more districts to give us reports. I think this is important so that we bring the country's health together.
Great, Dr. Palai. Thank you. And I know we've run out of time. We will definitely organize more presentations from the other districts. And also for the audience here with us today, anyone who would be interested in presenting, we welcome any presentation. With the holiday coming up next Thursday, we will not have a COVID webinar, but we will resume the Thursday after. And next in line, Professor Raymond from University of Saskatchewan in Canada, and he will present on COVID and its complications. I think this comes in at an opportune time with our limited experience. And believe it or not, even at Seki Tumile, we are learning every day. This may be a good time for an interactive session. I think with that said, Tommy, is there anything else, or can we sign off?
I think we can sign off, Dr. G.
Thank you all, and have a good evening. Bye.
Thank you.
Thank you.
Yeah, thanks everybody. Thanks. Bye-bye.
Thank you.